Hey guys, so it's Rowan, and I thought this would be a fun way to study for this exam. Because I've found that me personally, the best way that I learn is by teaching or pretending to teach in this case, which is actually called the Feynman technique, which is where you solidify your knowledge by trying to explain it to other people. So we're just gonna go through the study guide here, and I'm gonna give what my answers for all the questions on the study guide are. And if you guys get something out of it too, that's great. So we're gonna go through question by question, and I'm gonna give what my answers are. It's not necessarily the correct answer, but I did put quite a bit of work into it, so hopefully they're all correct. And I do have a pretty bad cough, so if the audio sounds weird, it's because I'm pausing the recording to cough and then restarting it. Okay, so starting on page 1 of the study guide, identify which phase of blood pressure, systolic versus diastolic, the coronary arteries fill with blood. So this is actually the coronary arteries, the arteries that actually feed the myocardium, they actually fill in diastole. And the reason for that is kind of weird. So when the left ventricle squeezes, all of the coronary arteries get squeezed as well, the tiny little capillaries. So that increases the pressure in those capillaries. So during systole, there's too much pressure in the arterioles of the heart for the blood to enter, and it has to relax. So during diastole, when the left ventricle relaxes, the blood can flow back down the aorta, and the valve is closed, so it's not going to go back into the heart, but it goes back into the coronary arteries. The leading cause of death in the U.S. is cardiovascular disease. Explain what happens during each of the following heart tones. So S1, this is the closing of the AV valves, the valves in between the atrias and the ventricle, so that the ventricles can inject blood. That's systole. S2 is the closing of the pulmonic valves and the aortic valves, so that for diastole, it's the end of systole. And then S3 and S4 are S3 can be physiologic, but S3 and S4 are normally pathologic findings. In S3, that's associated with heart failure. That's extra filling of the ventricle. And S4 is when the atria have to work hard because the ventricles are not compliant, they're stiff. So that's extra atrial kick into the ventricle during the end of diastole. And it says describe the sounds of each of the heart tones. And I don't know how to do that. I'm not a music major, so the only thing I can say about that is the order of them. Which is like this. So S1, S2, these are your normal heart sounds. And right after S2, there's S3. And then there's a pause, and then there's S4. And then quickly after S4 is S1. That's all I got for describing them. I'm not sure what they really want me to say about that. Describe a pulmonary embolism. So pulmonary embolism is just any blockage in the pulmonary arteries that are leaving the right ventricle and taking deoxygenated blood to the lungs. It's normally a clot of some kind, but it is not necessarily. Identify some signs and symptoms of a pulmonary embolism. Okay, so obviously, like most common bread and butter signs and symptoms, there's going to be dyspnea, tachycardia. You can low SpO2, low end tidal. One thing that irritates me is this S1Q3T3. sign that they keep talking about in school, this don't even like pay attention to this. This is nonsense. It's not real. I mean, it's real, but they actually don't tell us the full story. So when I was like looking into this, all of this, all this represents is what's called cor pulmonale, which is right ventricular strain, which can be caused by pulmonary embolism. Because if you think about it, if there's a blockage, in this pulmonary artery somewhere, and the heart is pushing against it, it's going to create more pressure back here. But it's not necessarily caused by this, and can be caused by any number of other things: pulmonary hypertension, pneumothorax, other things as well. Not to mention that it's so not only is it not specific, which is what we've determined here, because it can be caused by other things too. So if you see this randomly on an EKG, you can't say, this is a PE, because it's not specific. It's also not sensitive, and it occurs. Sources like kind of vary on how often it occurs, but it's as low as 10% of the time. The actual most common EKG finding in a PE is just sinus tach. Sinus tachycardia is the most common EKG finding in a pulmonary embolism. So don't rely on this. It's not real. It's not a real thing. So explain why intubating a patient in respiratory distress could cause bradycardia to occur. I think there's two main reasons for this. The first is the act of putting your laryngoscope in somebody's airway can cause vagal stimulation. And the other is usually when you intubate somebody, you give them drugs, hopefully, and you are taking away. If you're intubating somebody in respiratory distress, they're kind of like they're worked up. They're in a catecholamine surge. They've got tons of norepi circulating through their body. But when you sedate them, you give them ketamine or whatever, you're taking away that fight or flight catecholamine surge, which could just cause them to lose their sympathetic drive in general. So I think those are the two main reasons for that. Identify the most common presenting symptom in a male patient having a myocardial infarction. So I think this is probably just going to be chest pain. I think the key word here being male and common. Explain what is meant by atypical signs and symptoms of an MI and what gender is most susceptible. Atypical, it just means things other than chest pain and shortness of breath. So, nausea, abdominal pain, fatigue, which are all things that we should have on our radar, but they're still considered atypical. Identify the number one reason that cardiac compressions are unsuccessful during a cardiac arrest. Okay, I'm not quite sure what this question is asking. I think it is on. I would say, they're not done early enough, or they're of insufficient quality. But I'm not sure if this means like by bystanders or just why CPR is not effective in general. So I'm not sure. Identify modifiable risk factors for cardiovascular disease and identify non-modifiable risk factors for cardiovascular disease. So obviously modifiable is just things you can control. So diet, lifestyle, things like that. And non-modifiable is just congenital factors, maybe environmental factors. Yeah. Identify the most common dysrhythmia seen in patients immediately following cardiac arrest. So I'm assuming they mean other than So immediately following cardiac arrest. Okay, so this is going to be VFib. Describe the heart rate and symptoms most likely associated with second degree AV block type 2 and third degree AV block. So these high degree blocks, which is Mobitz 2 and third degree, they're usually bradycardic and often associated with, chest pain, altered mental status, stuff like that. Not that they're usually not benign symptoms. Identify the cardiac rhythm with no electrical or mechanical activity, so it's obviously asystole. Identify the rhythm which has multiple electrical impulses but no mechanical capture. So this is going to be VFib, or I guess VFib. It could also be like a pulseless polymorphic VTAC. Although I'm not sure if they're referring to like multiple foci when they say which has electrical impulses but no mechanical capture. I think this can apply to also PEA. This question is worded a little weird in my opinion. Identify the rhythm which has electrical impulses but no mechanical capture. So this could be like pulseless VTAC or PEA. Identify the cardiac rhythm with a fast heart rate greater than 160 regular and has narrow QRS complexes. This is going to be SVT. Keyword being regular and narrow and greater than 160. Identify the cardiac rhythm with a fast heart rate greater than 160 regular and has a wide QRS complex. This is going to be a monomorphic VTAC. Identify the cardiac rhythm that is irregularly irregular with a narrow QRS complex. This could be AFib. Explain the characteristic EKG pattern seen in patients with first degree AV block. Rates may be normal, fast, or slow. So first degree AV block is just prolonged PR interval. So we have our P wave, and then we have our QRS. Oh, that's a great looking EKG. But you get the idea. The PR interval is just long. Identify the characteristic EKG pattern seen in patients with second degree AV block type 1. So Mobitz 1 is the gradual lengthening of the PR interval. So then we have a P wave and it's longer, and then we have our QRS, and then we have a P wave and it's even longer. This is obviously a little bit of an exaggeration. And then we have a P wave and there won't be a QRS. So it's the PR interval gets longer and longer and longer, and then we drop a beat. Explain the characteristic EKG pattern seen in patients with second degree AV block type 2. Note that this rhythm has the potential to cause bradycardia. So in Mobitz 2, the PR interval is fixed, but there's still dropped beats. So there will be extra P waves without QRS complexes. Explain the characteristic EKG pattern seen in patients with third degree AV block. So in third degree AV block, you have complete atrial and ventricular disassociation. So the P waves, they march out. And imagine that those are all equal distance. And then we have like the QRS just thrown in there. And the key with this is that the rate, the ventricular rate and the atrial rate will be regular, but the PR interval will not be consistent. And you will often see like retrograde P wave. So like if we have this T wave here, you might see like a little like notched T wave, which can indicate a retrograde P wave. And this is often bradycardic, and the patient is in a bad way. Due to the typical slow rates and hypotension associated with second degree type 2 AV block and third degree AV block, what is the most appropriate treatment? Typically, you're going to pace these patients. Explain why atropine will typically not increase the heart rate in second degree type 2 AV block and third degree AV block. So the reason atropine usually doesn't work is atropine blocks parasympathetic stimulation of the heart, and usually these high degree AV blocks are caused by actual damage, physical damage to the conduction system, rather than like physiologic disturbances. Also, I hate the way that they say second degree type 2 AV block. Like, bro, just say Mobitz 2. It's so much easier. Okay. So, explain why you must always check for a pulse in transcutaneous pacing when you have obtained capture. This is just because you can have electrical capture without having a pulse, and you don't want to just assume you do. It's always good to make sure your patients have pulses. Identify whether you should set the pacing rate first or the milliamps first during transcutaneous pacing. So you set the rate first, and then you bring the milliamps up until you have capture, and then you raise them some more, and you feel for a pulse. Identify how many EKG leads are required to identify an AV block. So this question is also worded a little strange, because you really only need one to see the rhythm, because an AV block is a rhythm. It's not, you don't need contiguous leads. However, you might need multiple leads to see it clearly, because some leads can have more prominent P waves than others. And I also don't know if they're asking like how many leads on the monitor or how many leads on the patient. I'm assuming they mean leads on the monitor, so I'm going to say 1. Identify a problem that could occur with the cardiac monitor if the patient must receive transcutaneous pacing for an extended period of time. So for this one, I think a problem with the monitor could just be that it could die. You might have to plug it in. There could definitely be other problems too. I mean, running a significant amount of electricity through it for an extended period of time probably isn't ideal. You might want to consider taking them to the hospital, you know? Obviously you're taking them to the hospital, but yeah, for this one I'm not too sure. I think the answer is just it probably requires a lot of power, and it probably will heat up significantly. Describe what a dual chamber pacemaker does. So a dual chamber pacemaker is a pacemaker that paces the atria and the ventricles in sequence. So it kind of tries to emulate a natural rhythm. So it'll depolarize the atria and then depolarize the ventricles in sequence, as opposed to like a ventricular pacemaker, which just depolarizes from the ventricles. Identify what problem exists if you have pacer spikes not followed by a QRS spike. So this is failure to capture, and the heart is not being depolarized. Describe the difference between a fixed and a demand pacer. So a fixed pacer is a pacemaker that has a set rate that it will just keep pumping out electrical stimulus, into the heart at that rate, and it overrides any kind of natural electrophysiology of the heart. Whereas a demand pacemaker, if the heart generates its own electrical impulse, the demand pacer kind of takes a backseat and lets the heart do that. But then, if the heart fails to do that, the demand pacemaker will kick in and generate and depolarize the heart on its own. Describe what will happen to the oxygen demand of the heart if the preload is decreased. So if you decrease preload to the heart, you will decrease the oxygen demand of the heart because preload is the volume that it has to pump out. So you're decreasing the workload of the muscle, so you're therefore decreasing the oxygen demand. And afterload, this is the pressure in the aorta that the left ventricle has to overcome in order to open the valve and push and eject the blood that's in the left ventricle. So it's kind of confusing because preload is volume and afterload is a pressure, but they use kind of the same terminology. Describe what will happen with afterload in a patient with atherosclerosis. So generally it will increase because atherosclerosis, English is hard, is buildup of gunk, plaque essentially, in the inside of the arteries, which inherently narrows them and raises blood pressure. So this will decrease the diameter of the vessel and increase the pressure. Explain the concept of systemic vascular resistance and how it affects the diastolic pressure. Okay, so systemic vascular resistance is the resistance in the blood vessels that the heart is pumping against. So high systemic vascular resistance, if you have high pressure in the peripheral circulation, that's going to lead to high diastolic pressure. So the resistance in the small arterioles and capillaries, that determines the rate at which blood is drained out of the artery in diastole. So systole pumps the blood out of the heart at high pressure, and in diastole it drains out of the circulation into the tissue beds, into the capillary beds, and gets to the tissue. So if you have a very high systemic vascular resistance, you'll have a higher diastolic pressure, which is the pressure in the artery in diastole, and that is determinant of how quickly and how much blood gets drained out of the artery and goes into the tissue. Describe how an ACE inhibitor drug would reduce blood pressure. Okay, so an ACE inhibitor is an antihypertensive drug that people take to control their blood pressure. ACE stands for angiotensin converting enzyme. So we have this whole system, this renin aldosterone system in our body, and it kind of works something like this. So when you have decreased blood flow to your kidneys, the kidneys kind of notice this, and they convert this prorenin into renin. And prorenin is just in your blood anyway. It's kind of waiting for this to happen. So prorenin into renin. Into renin, and then renin combines with angiotensinogen, and that is going to make angiotensin 1. So angiotensin 1 is kind of like the dormant version of like this whole system, it doesn't really do much by itself. It just kind of exists to turn into angiotensin 2, which is what ACE does. So when you combine it with ACE, it turns into angiotensin 2, which raises blood pressure. And it does that by constricting arterioles. And it also increases sodium reabsorption. So, and we know that water follows salt, so increased preload, basically. An ACE inhibitor kind of deletes that, deletes this ACE, which stops angiotensin 1 from turning into angiotensin 2. So we kind of stop this cycle here, and we're just left with angiotensin 1. And angiotensin 1 is not really a vasoactive substance. So that's how it works. Okay. Describe what the pulse will feel like in a patient who is hypertensive. This is just going to be a strong pulse. Might be bounding, I guess. Identify a major risk of hypertensive crisis. So just anecdotally, I think we've probably all had patients like this who only take their blood pressure medication when they feel like their blood pressure is high, but they don't actually check their blood pressure and they don't take their blood pressure medication when they're supposed to. And I think that is probably a major risk of a hypertensive crisis, is just not being compliant with your medication. Although now that I'm rereading the question, I'm noticing that that is probably not what it's asking. I think I read this as identify a major risk for hypertensive crisis, but it's asking a major risk of hypertensive crisis, and that's obviously going to be like a stroke or cardiomyopathy, like left ventricle failure. So you got 2 for 1 there. So explain why rapid transport to the hospital is beneficial to the hypertensive patient, whereas suddenly administering a medication to drop the patient's blood pressure is dangerous. So we're kind of getting away as a field from treating hypertension because we found that it's actually super dangerous for the patient to just kind of bolus in these like beta blockers, unless they're very symptomatic and we have a good reason for doing it, like a dissecting aortic aneurysm or something else. But when we like administer these strong drugs that are going to drop their blood pressure, we're really doing damage to the kidneys and the renal system, and could potentially cause lots of other organs to become damaged as well. So yeah, basically the patient's body is used to this high blood pressure, or not necessarily that high of blood pressure, but they're used to high blood pressure. And if we drop the patient, down to 120/80, which, by the book is normotensive, for them that's hypotensive, and it could cause a lot of damage to them. So that's why. Define arteriosclerosis and explain why it most often leads to chronic hypertension. So arteriosclerosis, this is hardening of the arteries and arterioles. So they become less like elastic, and they don't increase in size as easy with pulsations. So that kind of leads to relative narrowing, which can lead to high pressure and hypertension. Identify which leads correspond to the following areas of the heart. So lateral, this is going to be 1 and AVL, and V5 and V6. So the high lateral 1 and AVL, and low lateral V5, V6. Inferior, this is going to be 2, 3 AVF. Anterior V3, V4, and septal V1, V2. So identify which EKG leads correspond to the right side of the heart and which correspond to the left side of the heart. Okay. So I'm assuming you mean in a standard 12 lead EKG without doing a right-sided EKG. In which case, like V1, V2, and AVR kind of specifically look at the right side of the heart. Um, you could kind of say that lead 2 looks at the right side of the heart, but from the bottom. And then the left side of the heart is like lead 1, AVL, V5, V6. Define the term contiguous leads. That's leads that correspond to the same area of the heart, like so lateral, inferior, anterior, septal. So V1, V2, those are contiguous for septal leads. So describe what you will see on the EKG in the following cardiac situations: myocardial ischemia and myocardial infarction. So with ischemia, we're going to be seeing maybe some inverted T waves or some peak T waves, some ST depression, and then myocardial infarction. We're going to see ST segment elevation and potentially Q waves after a while. So explain the differences between chest pain caused by angina and myocardial infarction. So with an MI, it's going to get better, or sorry, it's not going to get better, like with rest. And with angina, it's usually exertional or just kind of random and normal for the patient, and will get better with rest. Okay. Explain the difference. We just did that. Describe unstable angina. So unstable angina, as opposed to angina, is lasting too long. Like I think more than 20 minutes is the cutoff, or it's worse than normal. New onset. So if you haven't had it before, or if it's getting more frequent. Like it used to be, you had it like once a month, and now you're having it every day. That would be unstable. Identify the disease most responsible for angina. That's going to be atherosclerosis. Explain what collateral circulation is in the heart. So collateral circulation is when the heart, the body's pretty cool, and it can tell when your arteries are getting kind of clogged, and it will actually just build new ones sometimes that go around those clogged areas, which is super cool. Explain how nitroglycerin works to relieve or eliminate chest pain. So nitroglycerin is a pretty potent vasodilator, and it just kind of increases the diameter of the coronary arteries to alleviate some of that pain, because the blood flow is there might be more blood flow now, and so the myocardium's receiving enough, or maybe not enough, but more oxygen than it was before, so some of that chest pain is going to go away. Identify and list some of the potential side effects of nitroglycerin. So the most common one is going to be like kind of headache, maybe hypotension. I don't know if this is common, but I have seen someone get nauseous after this. I'm not sure if it was caused by the nitro. But yeah, I think headache is kind of the main side effect that you would see. Explain why we provide supplemental oxygen in a patient with myocardial infarction. So we do this if they need oxygen, don't necessarily do it just empirically. And we would do it if they were in respiratory distress or their oxygen saturation was low. But having higher FiO2 that you're breathing when you're having an MI could be beneficial, because your heart needs oxygen. But we don't want to give too much, because oxygen can be a vasoconstrictor, and that's not really what we want. Identify and list some common signs and symptoms of an MI. So obviously chest pain, shortness of breath, chest pressure radiating to your jaw, arm. Could be nausea, dizziness, fatigue, abdominal pain, lots of things. Define or describe cardiogenic shock. Sorry. So cardiogenic shock is hypoperfusion caused by a pump issue. So we have, you know, the heart itself is the reason um, for blood not reaching target tissue. Um, so as opposed to like hypovolemia, where there's not enough blood, but the heart itself is working okay. In cardiogenic shock, like there's enough of the other factors. Potentially, there's too much actually, but the pump is what's failing. Identify which position a patient is likely to prefer when experiencing signs and symptoms of an MI. So these patients typically like to sit up. You don't want to place these patients on their back, and you definitely don't want to put them in like Trendelenburg or something, because that's going to increase the pressure on the heart, on an already kind of sick heart. Explain why a patient having a left-sided MI would receive dopamine 5 to 20 mics per kg per minute instead of IV fluids in a hypotensive patient. So they probably, what they're getting at is, why would you not really want to give fluids to a left-sided MI, and why would a vasopressor be more desirable? And that's because, once again, the fluids aren't the amount of fluid, the preload is not the issue. The issue is the heart's ability to contract and push the fluid out. So adding more fluid to a sick heart is usually not the solution, because the heart is already having trouble handling what it already has, so there's no reason to give it more. You need to help the heart work harder, and be more efficient. Define hyperkalemia and describe what effect it can have on the heart. So hyperkalemia is a state of too much serum potassium, which is defined by exceeding, so it's greater than 5 millimoles per liter. So that's hyperkalemia. And it can have some pretty nasty effects, especially on the heart. So potassium, it's very important in the sodium potassium pump. We need it to generate action potentials and keep our cardiac cycle going. When you have too much potassium, it is going to increase the resting potential, the resting membrane potential of those myocytes. So it's going to approach zero. It's not necessarily going to get to zero, but it's going to become less negative. So it's going to get more positive, which is going to make it easier for those myocytes to generate an electrical impulse. So they're getting more excitable. So you can get some more ectopic foci potentially. You're going to get more uptake of those electrical impulses. However, that's only at first. So as K rises, it's going to get more excitable until a certain point, and then it's going to have the opposite effect, because the resting membrane potential determines how many voltage gated sodium channels are going to reopen to equalize the membrane. So if your resting membrane potential gets too positive, there's going to be much fewer sodium channels to kind of reset it, and the heart is not going to be able to generate enough action potentials, and that's what leads to death. Essentially, is you're going to have much slower uptake of sodium, which is going to lead to very slow conduction and cardiac arrest. All right. Identify the most common lethal EKG rhythm seen in cardiac arrest. This is just VFib. Explain why you must check for a pulse first before doing anything else in an unresponsive patient suspected of being cardiac arrest. So when you have an unresponsive patient that you think is potentially coded, you it's no longer ABC, it's CAB. So you check for a pulse first, and if they don't have a palpable pulse, you begin CPR before you assess their airway and their breathing. Um, After you have compressions going, then you assess other things. Identify and list some factors that should be considered prior to terminating a resuscitative effort in cardiac arrest. So you're going to want to consider the downtime of the patient, any rhythm changes, the current state they're in, things like that. Also, safety, potentially. Identify situations where you would not initiate resuscitative measures on a pulseless synaptic patient. So if you have a valid DNR signed in hand, you would not. Um, Also, if they have some injury incompatible with life, or they're rigored, or they're decompensating, not decompensating, decomposing. Identify how many seconds should pass before another breath is administered in a cardiac arrest patient with an advanced airway in place. So I believe with an advanced airway in place is 6 seconds. Define congestive heart failure. So congestive heart failure, this is kind of a disease process that affects the heart's ability to adequately manage the amount of volume that it has. So the patient's heart is no longer able to kind of keep up with the demands uh, of the body, which is going to lead to some kind of fluid overload, um, depending on where exactly the failure of the heart is. Could be the lungs, could be in the peripheral tissue somewhere. So identify areas of edema caused by right-sided heart failure. So in right-sided heart failure, we're going to see edema, depending on the patient, could be pedal edema, could be kind of sacral edema, depending on their mobility, um, peritoneal edema in their abdomen. Identify areas of edema caused by left-sided heart failure. So with left-sided heart failure, the edema we're most worried about, and where it's going to probably be, is in their lungs. And this is a big issue because that affects ventilation. Explain why left-sided heart failure eventually causes right-sided heart failure. So it kind of makes sense if you work backwards. So you start in the left ventricle. If the left ventricle is too weak, it can't pump out all the blood supplied to it by the left atrium. So fluid backs up past the right atrium into the pulmonary veins, into the pulmonary capillary beds, pulmonary arteries, right ventricle. So if the left-sided heart failure gets too bad, it's going to go backwards in time, kind of, if you think about it like that, and go to the right ventricle, which is going to cause increased pressure in the right ventricle. And that's going to eventually, chronically, could lead to right-sided heart failure. Identify the lung sound that will be auscultated in a patient with pulmonary edema. This is most commonly going to be crackles. It's going to sound kind of wet and maybe bubbly. Explain why CPAP is one of the most beneficial treatments for congestive heart failure. So CPAP increases the pressure in the lungs. So the problem with pulmonary edema, so we have our lung here, and we've got some water at the bottom. So the problem with pulmonary edema is that there's no gas exchange taking place at the bottom here, and we need more surface area. So what CPAP does is, because it increases the constant pressure, the continuous positive airway pressure in this airway, it's going to force expansion. So it's going to create more surface area, because you can kind of think of this alveolar sac like a balloon. And when you breathe into a balloon, when you inflate the balloon, the walls stretch, they become thinner and you get more surface area. So it's going to be more like this. And the water is going to be at the bottom. So the ratio of area covered by water is less in this one. So there's going to be more gas exchange. The fluid amount is likely going to stay the exact same. So that's a common kind of misnomer, is that you're pushing the fluid out of the airway. You're not. You're just creating more space for gas exchange to take place. Okay. So define the term aneurysm. So an aneurysm is just kind of the ballooning or the failure of one of the walls of some vessel or structure, which causes it to balloon outwards. Describe the signs and symptoms that a patient is likely to experience with an abdominal aortic aneurysm. So, and describe the signs and symptoms of a thoracic aortic aneurysm. So the main difference is probably going to be uh, the main difference in symptom is probably just going to be the location of the pain. I guess there could be other kind of like fringe symptoms, like abdominal aortic aneurysm could probably cause some nausea, potentially vomiting. Thoracic aortic aneurysm could, depending on the location, could affect some other things as well. Like it could compress the vena cava potentially, or the esophagus. Um, it kind of the thing with thoracic aortic aneurysms, you can kind of speak broadly about them because it depends if we're talking about the aortic arch, the ascending aorta, the descending aorta, things like that. The signs of an abdominal aortic aneurysm, the main thing you're looking for is that kind of palpable pulsatile mass in their abdomen. Um, and with a thoracic aortic aneurysm, you're not going to have that because you won't be able to feel it through the chest wall. Explain what defibrillation is and does. So defibrillation is the process of administering a pretty substantial shock to a fibrillating heart in an attempt to completely stop this fibrillation and return the heart to a normal or more normal rhythm. Explain the process of performing defibrillation. Okay, so you're gonna turn the monitor on, put the pads on them, analyze their rhythm, charge the monitor, which you can do before you analyze their rhythm. Charge the monitor and administer a shock. And you're going to do this in VFib and pulseless VTAC. Explain the difference between synchronized cardioversion compared to defibrillation and how it works. So synchronized cardioversion is when the monitor is kind of tracking the R waves in the rhythm of the patient and administers a shock on the R wave in order to avoid um, uh, delivering the shock in a vulnerable part of the cardiac cycle. And because it's kind of timing these shocks well, you can it generally can use less um, electricity power. Automated external defibrillators should be applied in what situation if a manual defibrillator is not available? I'm not so sure I understand what this question is asking. I guess you would apply it in any situation where a manual defibrillator is indicated. So, cardiac arrest. Describe pulsus paradoxus. So, pulsus paradoxus is a decrease in blood pressure during inspiration. That's all that is. Explain the function of aspirin in a patient having chest pain and why it should be given immediately, as well as nitro and morphine. Okay, so aspirin is a platelet deaggregator. It makes it so that the the platelets going by, so after like a plaque kind of breaks off from the wall of an artery and travels downstream, there is damage to the wall of that artery, and platelets want to go there. Um, And so having a platelet deaggregator given immediately is going to be beneficial because it's going to prevent kind of further blockage. And the purpose of nitroglycerin is just to expand the diameter of those blood vessels and increase the blood flow, kind of distally. Explain the effects of morphine sulfate administered to a patient with chest pain and what effects it will have on oxygen demand. So morphine, it's an opiate, so it's going to be beneficial for their chest pain, just by kind of nullifying the pain sensation. But it also can be a vasodilator. It's fairly vasoactive. So hopefully that will decrease the oxygen demand of the heart and kind of reduce chest pain in that way as well. So for that reason, that's why morphine is sometimes preferred, and it also is pretty long acting compared to like fentanyl. So that can also be a decision that will play in on why people give morphine. Okay, final page. Describe the following skin conditions associated with these cardiac conditions and what color they will present as: cyanotic, flush, jaundice, mottling, and pallor. So I'm not super sure what this question is asking. Is if we're just describing what these words mean. Cyanotic is obviously kind of bluish hue of the skin, usually because of um, poor circulation. Um, being when you're flushed, you're kind of red, and jaundice is yellow. Increase of bilirubin in your blood. And just kind of generally that can indicate poor cardiovascular health. Mottling is reduced blood flow. This is probably this and cyanosis are like the most concerning of these. And pallor is just kind of pale skin. This is more like kind of like cyanosis, but more not blue, so not as like acute, more like chronic lack of circulation. Explain why aspirin should be your first line medication in a patient experiencing myocardial infarction. So aside from the way aspirin works, I believe aspirin is actually the only drug that's been proven to have like reduction in mortality. So you want to get it on board as fast as possible because that's going to be what's actually been proven to help the patient the most. And then also thinking about it, just what it does, you want to have that platelet deaggregation effect as soon as possible. Describe the properties of these terms of the heart. So chronotropy, this is speed. This is the speed of the contractions. Dromotropy, this is the kind of like the ease or the speed of the electrical impulses themselves. So not really related to the mechanical aspect. And then inotropy, that's the force of the contractions. So identify at least 3 commonly used antidysphorinemic used to treat multiple PVCs. So I'm assuming they mean like something a patient would be prescribed rather than something we would give the patient. I'm not sure though what exactly they're asking, but it's going to be they're going to have maybe some beta blockers, and then potentially like either diltiazem or amio. I think those are probably the three most common medications. Beta blockers not being a specific medication, but if they don't have a beta blocker, it'd probably be one of those two for this. So the drug furosemide is a non-potassium sparing diuretic. So what prescribed supplement would the patient likely be taking? This answer to this question is pretty obvious. It's in the question itself. They're going to be taking a potassium supplement. Explain why you should wear gloves when administering a nitroglycerin tablet to a patient. So you should probably always be wearing gloves if you're administering a medication in general. So this question is kind of silly, but you should definitely be wearing gloves when you administer nitroglycerin so you don't get it on your hands. And also because it's going in their mouth. So definitely for several reasons you should be wearing gloves. So describe how dobutamine works. So dobutamine is mainly an inotrope. So it increases the stroke volume of the heart mainly through the force of the contractions without increasing the heart rate too much. And dopamine has inotropy and chronotropy. So kind of your more classic, like vasoactive. It's going to increase the heart rate and the work of the heart. So if you found this kind of useful and fun, then great. If you didn't, then I'm sorry. Hopefully you got something out of it, if nothing else other than the answers to the study guide. I find this helpful to imagine myself explaining it to other people. It kind of helps solidify knowledge for me. So thank you guys.